looks like people might be straggling in off clinical service. So I'll start. Hi, I'm Dr. Carolynn DeBenedectis, and I'm the chair of the APD committee, and I will be moderating the session. The purpose of this session is to get feedback to the ABR about the initial certifying process for trainees, as they are looking for some feedback in order to, help them see how the process is going. We have guests from the ABR today. Dr. Brent Wagner, the executive director of the ABR, will be joining us. Dr. Desiree Morgan on the board of trustees for the ABR is joining us. From the ABR, we also have David Laszakovits, who is the director of communications for the ABR. We have some PDs here, myself. I am the PD for Umass Chan Medical School. We have Dr. Anna Rozenshtein, who is the PD for Westchester Medical Center. And we're hoping to be joined a little later by Dr. Mary Scanlon, who is the PD at UPenn, and Dr. Ernie Wiggins, who's a former PD. So we will get started by having Dr. Wagner from the ABR present a few slides to kind of clue everyone into more details about the conversation we're going to have and why. Take it away, Dr. Wagner.
Thank you. Let me share my screen and I hope you can see my slides. So I'll just give an overview of kind of what we've been working on for the last, well, I guess dating back to last October, so about 8 months. And we are trying to gather feedback on the diagnostic radiology initial certification process, which for practical purposes consists of 2 exams, the core exam, as you know, and the initial certification exam, which takes place 15 months after residency. The, excuse me, we're looking to seek stakeholder inputs and insights with the goal of engaging interested stakeholders. And I don't think anyone's a more valid interested stakeholder than the program directors in diagnostic radiology, but you'll see that there are others that we're talking to as well. We have held third-party moderated sessions, which were focused on gathering information and perspectives before we consider possible modifications. And our goal here is continuous improvement. So we haven't decided that we're going to modify anything. That's going to be based on what we hear from you and other groups, and of course on some internal discussions as well. And I do want to state at the outset, if we do make a change, we acknowledge there has to be a lot of lead time for the trainees and the residents, a lot of lead time for the faculty and program directors, so that in effect, our intent is to announce any significant modifications if we decide to go that route with enough advance notice that it wouldn't impact current trainees. So that's a kind of a soft guideline, I think, that is useful to you, I hope, in reassuring you that if a resident is already in training, they can anticipate there won't be substantive changes to the exam paradigm that currently exists. So there's a phase 1, which is the discovery. That's where we are now. We're interested in hearing from you. And as I say, this has taken a couple different forms, including our third-party consultant who has run some of these sessions so far. This one's a little more informal, and I hope we can further gain your thoughts and your input on this. If there is a need for solutions, that would begin later this year. And as you can see, we kind of have that caveat there that only if this discovery process indicates that a change is needed. And just to repeat, we're not going to do anything without significant notice that allows people to adjust accordingly. And as I say, that's where we are now, is in that phase 1 discovery phase. The stakeholder groups, this is only a partial list, but I think it covers most of the people that we're really interested in hearing from, the people who would be most apt to give us useful input and probably have the biggest concerns over what changes might be considered. The program directors themselves, excuse me, the APDR, obviously APDIR, and also the vice chairs for education research. We've talked to them as well. I'll be talking to the ACGME RRC next month. We talked quite recently to the chairs in academic radiology departments, We've also talked to current trainees through our own advisory committee, through the AQ group, and through the SIR early career section. So, and then also we have met with the ACR leadership because there were concerns about sort of what this means for private practice and general practice. As you know, most radiologists don't wind up in academics. Are they well prepared? Are our testing instruments effective in what that lends to the production of a qualified radiologist? We also have a publicly available survey, so that's available to anyone who wants to contribute. So in some ways, we're talking about individual organizations such as APDR coming up with something akin to a consensus statement. What does the APDR as an organization represent? But in addition, any individual can log into our publicly available survey. That's going to be extended through at least August 15th. And we're looking forward to input there as well. So I'll close with this slide. As I say, we're really looking at this as a discovery phase and getting along to a stakeholder report, discovery report. And this all covers a timeline that began in May, and we will close out by November. Now, the important thing is that in November is really the first time we're going to be considering looking at solutions rather than is there a problem and what is the nature of that problem, if there is one, regarding the testing instruments we have. So at this point, let me close here. Obviously, we're going to be around for questions. If there's something that I said that needs clarification, be glad to follow up with that.
Wonderful. Thank you, Dr. Wagner. I appreciate it. Set the stage for what we're about to discuss. So now Dr. Anna Rozenshtein has done some surveys through the APDR membership to kind of gauge the feelings about the ABR initial certifying process. And she is going to share those results. And then after that, we can have a discussion. So Anna?
1 second.
Sure.
Yeah, we're handling multiple open windows on a fairly small screen. And I think, here we go. Can you see my screen now?
Yes.
Okay. So as the current president of the APDR, it fell on me and the board and the survey committee to prepare us for the consensus statement. And in order to have a consensus statement, we needed to have the opinions of our members. And so approximately 2 weeks ago, we sent out a survey which mirrors the comment page of the APDR to our entire membership. And I'm about to present the survey results to you. It's brief. We only have something like 9 slides. But before we start, I would like to tell you that we have around 300 members and 72 respondents care to give us the comments. And it feels like a fairly low response rate, about 25%. But in fact, this came really, time constraints at most difficult time for PDs. It's when we onboard the new residents and when the major vacation time is happening. So both the clinical service is hopping and we as PDs are very busy. So, 25% is actually not bad. And as you can see from demographics, we are, the respondents were very well represented across program size and setting and the geographic region. And they came from various lengths of service. They're very experienced PDs, over 10 years of service, or PDs with just several, years in service. Majority of the respondents were current PDs. Okay, so first, let's do the sort of good news for what's going well. Okay, so regarding knowledge and clinical competence, you notice the majority, could be small majority, could be sizable majority, feel that both the core and the certifying exam, the first and the second, do well or very well. Okay, and about 2/3 feel that the radiologists who pass the certifier, our outcomes, are prepared for clinical practice, well or very well, right? And by the way, the rest of the respondents were largely neutral, okay? That the initial certifying exam is less biased than the oral. Okay, and that's the feeling of the majority, over half of respondents. And then the current timing, so 15 months out, after the end of residency, was, okay, is appropriate. And those who, by the way, responded negatively wanted it back at the end of residency. Okay. Now, to your question, whether the initial certification exam needs improvement, we asked for comments, and the two, statements were trending. Okay. First of all, multiple choice questions do not test the skills needed for daily practice. What kind of skills? Well, it's coming. And the trend was the communication skills are the one item that was not tested. Okay. Now, what parts of the exam work well? Okay, so if you notice, the majority cite medical knowledge. We had some multiple parts, and in those multiple parts, the majority had medical knowledge with either physics or interpretive skills. And what was lacking, and I checked every single response, okay, was communication skills. That these tests, as compared to the oral, do not test communication skills. Right now, an important question. Should the certification exam, we're talking about the second, right, the certifier, test general knowledge? 100% of our respondents feel that yes, or it at least should be optional. That's fifths feel that at least should be optional. And, 4/5 feel that yes, it should test medical knowledge. The question is, should it test subspecialty knowledge? And, over half say yes. And a third say, yes, it should at least be optional. Only a very small minority feel that no, the certifier should also be just general, right? The majority feel that it should be either some knowledge or at least option. Now, that's not great opinion. What is the impact on preparation for radiology practice compared to the oral exam? And the actual question is, we all know that we as program directors, are responsible for our trainees to pass first and the second board exams, and therefore we will make sure that they are trained to the test. And 57%, over half, felt that the switch from oral to the new paradigm had a negative impact on training. Now, there was a specific question on multiple choice, the ability of multiple choice tests to assess interpretive skills, communication skills, and professionalism. And interpretive skills, not very well, 57%, but neutral and well, 15%. I mean, we're not terribly happy with it, but it's not too terrible. But basically, very few people, 1%, feel that the testing communication skills well, and nobody thinks that multiple choice questions do anything to test professionalism. And again, we're bringing back to, right, coming back to the question, what impact we have, right? Now, this is the last slide of the actual raw data. What should the ABR keep doing? Really big trend here. Please keep the virtual/remote format. That made a big difference, and program directors are grateful. What should the ABR start doing? Trending. That doesn't mean that the majority think so, but there's a trend. Go back to oral examination, or at least incorporate interactive component with testing communication skills. Conclusions, right? So kind of, mixed, mostly good news. The core and initial certification exams do well testing medical knowledge and clinical competence. Trainees who pass the certifier are, majority thinks that they're prepared for independent practice. The DR initial certification exam is less biased than the old oral exam. And at the current timing, is probably appropriate. Now, the majority also feel that the switch from oral to the new certifying exam had a negative impact on training, and they support and encourage the ABR to continue offering virtual remote testing. And there's something here that is kind of unusual amongst public director, and that's unanimity. And we are unanimous in that neither the core nor the certifying exam test communication skills or professionalism, and that the final exam, the certifier, should test general knowledge. Thank you. You were the first audience for me to share these results.
Thank you, Dr. Rozenshtein. Thank you very much. Okay, so it looks like, Dr. Rozenshtein gave the survey results. She also happens to be a PD as well. Dr. Wiggins is on, I am on. So I thought we could maybe give some thoughts. I don't know if everyone's already heard from me and Anna, so maybe Ernie, would you like to chime in about your thoughts on the survey and your thoughts as an educator on the core exam?
Sure, thanks. Yeah, I mean, I think a lot of what Anna presented is consistent with just the comments that you hear just in passing whenever things are discussed. One thing that did catch my attention in that was just the idea of bias and being less biased with the oral exam, because I think if we were to do a little bit more of a deep dive into that, we may get some comments about just the biases of standardized testing as well, and whether or not the oral exam. I know the initial thought when people hear bias is just that the examiner has a bias directly against the examinee potentially, and obviously that would go away with it goes away with the written exam and not so much an oral exam. But I think if we were to look at that a little bit deeper, we may get some different responses about that. That would be my only comment.
I'll follow up because I agree too. Does the ABR have any feelings about bias and multiple choice? Or was it looked at maybe before the initial? I don't know how many of you were involved in the initial decision.
I can comment on that if you like. We don't collect race and ethnicity data, so it's impossible really to establish differential item function. For example, we're actively looking at that because we may be able to actually extract data from AAMC or ACGME, which would immediately, we could apply that to people already in the pipeline. Otherwise, we have to start collecting it prospectively. So that's been an active focus for the ABR for the last couple of years. ABMS, unfortunately, although they're trying to support this, and I had a conversation with them just last month about this, it's been slow going. So I don't have much on differential item function. We do collect gender information. There has been no particular trend in looking at gender, because that we have collected for years in terms of multiple choice performance. So it'd be a little surprising. When I look at, for example, differential item function and the kinds of items that that cross cultural boundaries, an awful lot of radiology really doesn't, for the most part. I suppose we could argue about differential diagnoses about some diseases that are more prevalent in different parts of the world, including the United States versus other continents and other countries. But when I hear this at ABMS, the differential item function is usually related to cultural preferences in terms of therapy, care of a patient, as opposed to does that CT scan represent a glioblastoma, that kind of thing. So, but yes, it is on our radar, and I hope that a year from now we'll be collecting meaningful data. As far as the bias in the oral exam, there again, we don't collect race and ethnicity information. We have had no indications that there's any bias in that regard, but difficult to exactly measure.
Okay, great, thank you.
Thank you very much. I'll actually go next because of some stuff Ernie said that I wanna go off of, and then Anna will let you go after that. So I think more than, of course, more than even the bias, racial, gender, or other biases, I think this test, in my opinion, biases good test takers. I think that there were, first of all, issues with both tests. I don't think the oral boards were perfect. I took the oral boards and I took the other certifying exam, the writtens and the physics boards. And I don't think that situation is perfect. I don't think this situation is perfect. I don't think even after all the wonderful work the ABR is doing to get all this feedback, that even if there are appropriate changes made, we'll ever get a perfect exam, right? It's difficult, but I do feel like it benefits good test takers. There is definitely evidence for me of those that struggled on their USMLE definitely struggle on this test. Again, it's a, multiple choice test. The way the residents study for it bothers me a lot. So I'm not going to say I felt the oral boards tested my knowledge. I don't think they did. I think I think studying for the oral boards allowed me to accrue tons and tons of knowledge by being put in the hot seat multiple times a day, every day for multiple months. It put the pressure on me to study. I learned how to take cases. I learned how to think critically about cases. And so the oral boards benefited me from that point. No, I do not feel all my knowledge I studied was tested on the oral boards. I also agreed the cases were flawed in some cases. There were all sorts of problems with the oral boards, so I'm on board with that. What bothers me now is the board I took that I thought was the biggest waste of my time, which was the written boards, which were that, not your physics boards, but that written boards where I remember my senior residents saying, take all these questions and just study them. And that is how I feel from observing my residents, that the studying for these boards have gone, that do more questions, that there's even information that my residents told me is out there that you have to do X number of question bank questions, and that kind of means you'll do okay. And what I've seen them is wanting to do less and less hot seat oral board review, which I think does give them lots of knowledge. And as I said, I think it's one of the things that pushes them to learn a lot. But I've seen them over the years less and less ask attendings to do it. Now, it might be a double process. Attendings want to do it less. I know at first when the oral boards went away, we had actual whole attendings saying, well, I'm not going to give board review for a multiple choice test. So I definitely know that that is part of it too. But I definitely don't love the way I see them studying for it. I worry, are they going to be able to, from their studying, still get the knowledge they need and the skills they need to, when a physician comes in to go over a case, to be able to actually critically think and do what you need to do. So that's one of my major issues. Two last issues is the 15 months after fellowship, 15 months after initial certifying exam, where they take their boards during their first attending year. As somebody that is also takes a big part in hiring at my institution, we're seeing a lot of late starts. And I'm sure all of us are in the same situation, that we're having staffing issues, we're all understaffed, and we're dying for that July 1st date to come. And what we're seeing happening is people saying, can I push it more because I'm studying for my boards? And so we're seeing a lot of first year attendings start later if they're right out of fellowship, because they're too nervous to start right away, because they're afraid becoming a new attending and all the clinical volume that there is, they're not going to have enough time to study. So I do think that 15-month mark can present a problem for new hires. Of course, there's other problems if you moved into fellowship. Trust me, I know there's no perfect time, but I definitely wanted to make a note that we've definitely noticed that this year we're really struggling staffing our ED, because a lot of them with nights, they're like, well, I don't want to start ED nights while I'm studying for an exam. So a lot of them aren't starting till the fall. So just to put that out there. And then lastly, the one thing we talked about, communication skills. I agree. As somebody that's done a lot of research in communication skills, written papers on it, I definitely think it doesn't test communication skills. The other thing I'd like to see is some of these non-traditional core competencies that are required be put on it, specifically healthcare disparities. I really think that this test should include a little more on healthcare disparities in radiology as part of maybe the general or part of the exam, because I think it's something really important now. And I think that it should be in there with some cultural competency stuff to show that it's important to motivate these residents to actually learn about it. And if we're putting it on the board, it shows them it's important. It shows them it's important to their career as radiologists. So that's just my last little suggestion. Anna, anything you'd like to say? I know you gave all your beautiful survey results with a little commentary.
I think I already spoke offline, and my opinion has been noted, but what I wanted to say is that when you talk about biases in real life, and we're talking about biases in the survey, that's a different story. We, again, mirrored the question asked by the ABR, and our the lead into the question was all tests have biases. We just wanted the opinion of our members. What do you think? And our members, we hope, Ernie, Carolynn, they understood that all biases, for example, we know there's a large body of data that multiple choice questions, are not great, in minorities. They don't do as well, for one reason or another. So there's clearly a bias going on, right? But still, our members felt that overall, it was a less biased test. And again, it's only a small majority, 54%, but it's a majority nonetheless.
Thank you. Thank you very much. Okay, so I'm happy to open up. If what we can do is if people have questions or comments they'd like, if they can put them, it looks like the best mode I'm trying to see here is into the chat. So if you have questions, comments that you would like to give the ABR feedback and you are on this call, we would very much appreciate it. If you put it in the chat, I'm happy to share it. In addition, Dr. Wagner, Dr. Morgan, do you have anything that you heard from us, Ernie, me, and Anna, that you would like to respond to in any way while we wait for some comments in the chat?
So Brent, if it's okay with you, I have a question that in looking back from 2010 to 2013, as we were gearing up to change the paradigm to what we currently have now for the diagnostic radiology certification process, one of the biases was also large program versus small program and the access to these extensive question banks, which I think in the time of, internet and connectivity may or may not be as much of a problem, but there are some complaints that we hear from folks about a bias, small versus large programs. And I just didn't know if anybody here on the call can look with that perspective at what currently is happening with the paradigm we have now for testing in our initial certification.
Sure. Thank you. That's wonderful. That's a good question. I'll give a little comment as a small program, but before I do that, sorry, the chat is disabled. Please put your comments into the Q&A. That is my error. Thank you. I'm a small program and I see no issue with having access to the Q&A, to question banks. I'm fortunate enough that we're able to purchase it. We have the finances. We are a part of a bigger institution, despite being a small radiology residency in size. And we've had no issues affording the Q banks from that point of view. I will say when it comes to oral board review, if you give oral board style review for the boards, we have a huge faculty despite a small program. And that's also not an issue because we have so many attendings, but I could see if you're a small program with a small faculty, having faculty to give individual board reviews may be challenging. But I know from our point of view, affording the Q banks is nothing for us. I don't know if anyone from a larger program would like to comment.
I mean, I could also comment from a small program, both in terms of resources. Really, there are no issues getting enough resources for studying. I think a lot of the issues come in terms of resources for some of the non-interpretive skill requirements and making sure that there's appropriate education for the residents in those areas. One of the strains for the small program is always just kind of coverage as the residents are preparing for the exam. Not saying anybody gets any time off, but just in general, that people aren't as engaged when they're closer to the exam time, and so that can be a challenge for small programs.
Well, actually, Ernie, I think next year the ACGME is actually allowing board study time.
Okay.
At least AUR, they said that it's half days for so many weeks before they were toying with. I didn't see the final yet, but and we also did a roundtable on this that showed most people are giving time off anyway.
I know.
But no, I agree with you. That is Ernie, I struggle with that in a small program too, is the scheduling call around the boards, because even if they're not getting time off, they want to take less call around the boards. And when you have a small program, yeah, Ernie, it is much harder to pull from a smaller pool to cover multiple weeks of call. So I agree. I think if the new ACGME rule about board study goes through and there's mandated that everyone gets, I think it was 6 weeks of half days leading up, small programs can be hurt by that. But I think having an ACGME mandate actually helps with that a little, because it might have been biased before to big programs where there was enough coverage so they could give people time off, whereas some of these small programs might have not been getting time off despite it was being illegal for everybody. And now at least it would, level the playing field a little. I agree, Ernie.
Good point. Thank you.
Let me see. I've got some Q&A, so I'm going to read them off. Why did the ABR change the core exam score reporting back to the programs? Looking at the individual score reports and quartile reports was important for program evaluation and development. Great question. Someone from the ABR, would you please like to address that?
I think it's probably mine. I just want to comment before I get to that question. It's a great question, but the question bank issue, back when I was board certified and took a written exam followed by an oral exam, the question banks were considered very important. They may have been, obviously there was some controversy over whether or not it was ethical to even establish them or use them, et cetera. I think in an era, both the core and for the certifying exam, where there is such a large number of image-based questions, and credit to Dr. Morgan and her colleagues for writing an exam that is really built around images, it's almost impossible to share those question banks. I mean, it really is. You can't reproduce that renal cell carcinoma or that GIST tumor that you saw. You really can't do that in a meaningful way to help people. So I would hope that question banks are much less relevant than they were in the past. There are still some questions that I know kind of percolate along that are not image-based, but for the most part, question banks are not what they were in the 90s and early part of the 2000s, when we still had an oral exam that looked at images and a written exam that did not. So, but let me answer the question regarding the individual score reports and the quartile report. I would agree 100%. Looking at the quartile report is important for program evaluation and development. I'm reading the question right out of the Q&A. There's no argument for that. The Board of Governors agrees with that. The ABR staff agrees with that. We would agree quartile reports or something akin to that. And we're actively looking at the ways to do that. We had a meeting set up for last week. Unfortunately, it was canceled, postponed until next month, but we're listening to program directors. What would you like that report to look like? And honestly, we're probably going to float a draft, because we can always change it. If you don't like it, we'll change that nature of that report. Currently, we're looking at something very similar to what was being released before, which is what is the national average, for example, in neuroradiology? What was the performance of your program in neuroradiology, that kind of thing, and in terms of the scale scores. So we can do that, and it's already in the works to go ahead and release that. I would take issue, though, looking at individual score reports. I'm not sure the Board of Governors certainly would agree with me. That's not important for program evaluation development. That's an N of 1. And those individual reports, what basically carried the day in that discussion was that those individual reports may actually be very helpful in helping a given candidate do better the next time if they failed the exam. But the ABR exam was never intended to be a comparative between the relative performance of two candidates, one versus another, both of whom passed or both of whom failed. It really is a pass-fail designation. And unfortunately, because of the timing of this decision, this was new information. The board itself was unaware that this was done. And I want to stress, this is not just about diagnostic radiology. It exists in radiation oncology, it exists in medical physics. And we just decided that in today's day and age, it's, privacy is important. And, we'll continue to give out pass-fail information regarding your candidates, because that information obviously is important to you, the ACGME, the department, et cetera. But to get down to individual comparative scores, it's not what the test is intended to do. And if we're weighing that balance about, sort of resident privacy versus what the program directors should know, the residency privacy kind of won. In fact, I had a debate recently, but we can't very well say that it's unimportant to the residents, so go ahead and give it to the program directors, because if it's unimportant to the residents, they'll share it with you, and they're certainly allowed to do. They can put it on Twitter for all I care. They can post their score sheet wherever they like, but it's theirs to make that determination. And I'm glad to discuss this further. I just don't want to sidetrack us into that. Incidentally, if anyone who wants to reach out to me directly at the ABR, just email. I mean, my email is pretty easy. It's bwagner@theabr.org. I'd be glad to talk one-on-one with anyone who has concerns in that regard. But as I said, I don't want to sidetrack this conversation. That said, if there are other questions about this or anything else ABR, I'm glad to listen and respond.
Thank you. I'll make a little comment on that, of some with some experience with this. So I will say that the first thing, so we have something called the Center for Academic Achievement here, where people that are struggling can go. And usually if somebody fails the core exam the first time, I have them go to that. And I will tell you, the first thing they ask me for is that individual score report that the PDs don't get. But what I'll tell you, I've had no issues with the residents being willing to hand it right over. You know, I think if you're going to get academic help for them, I mean, it behooves them to hand it over. So even if you don't have it, I think the residents usually freely hand it over to any sort of academic assistance that requires it. All right. So thank you very much for that explanation. I appreciate it. All right. So next we have some more like some comments. You know, I think Dr. Scanlon was talking about interpretation of the data, and I think what she's saying is valid, that it was like a 54% majority are happy. So it's a small majority, and we don't want to overstate that to the ABR, that, well, there was a majority, 54% saying they were okay with things, that is a small majority and should be viewed appropriately by the ABR, that it's not an overwhelming majority, that there are still a significant number of people with significant issues with the current format of the exam. So I think she wanted to reframe that to the ABR to make sure it was taken in the context fully. And then Mary also said the ACG meeting does not give specific board time. So that's what I was at the RRC at AUR, and they were talking all about these half days being allowed and all this stuff. And I guess maybe it never materialized because it was a prelim suggestion and to be voted on. But either way, what I will say is I do not feel the residents request any less study time or make any less of a big deal of this test than they did the oral boards. From a program point of view, there's still a lot of limited help during those months, any way you do it at your program. So I agree with that. Anyone else? I think that's all my questions I have in the Q&A. Any comments, questions, anything? You know, this is your chance as a PD or anyone involved in resident education to voice your input to the ABR. I'll tell you, I've worked at the ABR before in these, and they take very seriously all the recommendations made. So your recommendation will be taken to heart from what I've seen working with them. So I'd highly recommend, if you have some good ideas or good suggestions, to throw them out there. This is your chance. You have a captive ABR audience who will listen. All right. Oh, okay, that's the change. Okay, so now they say you can have study time, so now no one has to lie about it. All right. But I will say, from a service point of view, now that it's okay to admit it, if they have study time, they have not wanted any less than before. I have seen zero change in the amount of study time they want for the boards compared to oral. And I don't know if Ernie or Mary or Anna can comment differently about their programs. If they see any less stress. If anything, I've seen a little more stress around these boards than the oral boards. I don't know if it's a generational thing or what, but.
Personally, I didn't see any difference. Yeah. Except the fact that, you know, our residents, when I tried to still do the hot seat format, how shall we say, there was a little less satisfaction than when I did a classic, you know, new board prep, you know, multiple choice questions, a lot of images, and etc. So I think they are way less stressed when we teach to the test, and they feel certain that they will be familiar with the way the test will be structured.
Yeah, no, I agree. I do think the structure of the test definitely makes them want to take cases less. Which is, as an educator, and I think I saw Ernie nod as well, and clearly Anna just echoed those sentiments. It is just, I wish there was some way to get over that with them, and to realize that the hot seat does help them on the exam, as much as, you know, they're told, do question banks, do question banks, do question banks. I do think the hot seat does help them in the exam. And even if it doesn't help them as much as the question banks, it's going to help them in real life. And I don't know if there's a solution in an appropriate way on a written exam to get that through. I know you guys tried in some ways with questions, but I do agree that's a big issue. But I think one thing that I think was unanimous that I want to point out is the virtual format is just, you know, I think that cannot be overstated. I remember that year of going back and forth about what was going to happen. I think with the way COVID is now and everything, I mean, now, even if they have COVID, they can take the exam. Like you know, because they're isolated in their house. So like, I think given the current climate, that is just such a huge stress relief to the residents, to be able to take it remotely and not have to travel in person. So to the ABR, if there's one comment I'd take home is don't change that. Any other comments? I know poor Mary, I'm not sure, Mary, if you're in the right, there were a panelist link. I'm not sure which link you ended up getting. I don't know if Caitlin can fix your mic issue, but we'd be happy to hear you speak. If we can fix your mic issue, I don't know if we can unmute people who are not panelists. Unfortunately, Caitlin can figure that out. Anything else? You know, we still have some time here. I would love to get as much feedback to the ABR as possible.
Carolyn,
Oh, it
this
seems
is, oh, go
it's
ahead,
Mary
Mary.
Scanlon. So thank you. I've finally been unmuted, but I agree with everything you said, Carolyn. Absolutely, and how you expressed what I commented on was perfect. I love you madly, Anna, but I think your whole interpretation was a glass is half full, and I think it's really clear that the conclusion should not say that this is definite. The majority was very small, like 53, 54%. So. And I'm a full believer. We really need to go back to some sort of oral exam, and you know we need to train our residents that they can speak to clinicians. And life is not a multiple choice test. When I sit down and read a head and neck cancer case, and we're not teaching them how to think and to interpret because they just want to study for the way the exam is.
To that end, Mary, and I would like to pose this to all the folks who are on the current Zoom. So one of the things we do for ACGME is poll our recent graduates, and certainly the ABR is trying to, in that list of stakeholders, you saw that we're approaching the ACR, our volunteers, our current residents, but really no one can volunteer until they're a few years out. And so it's really important to understand how well people feel they are prepared for practice. And so some of the questions we asked, we're talking about, you know, how do the multiple choice questions do preparedness for practice? Do you have any information, or do you all hear back from your graduates? Oh, I wish I'd had more hot seat conferences because once I got to practice, you know, it's not a multiple choice test question world. I mean, can anyone speak to that kind of input that you might have from your recent graduates in your surveys, if you do them?
I haven't heard that from the recent graduates because they haven't spoken of that, but I have heard from practices across the country of people that are hiring our folks, that they're not the same quality, not the same folks that we turned out before we got rid of the oral exam. So I think that's the group you need to look at, because they don't know any difference, the new graduates. But the people that...
I would agree with that. Desiree, graduates, people in general tend to overvalue their performance. It's a known fact. Everybody is better than average driver. And since the graduates had no opportunity to experience prior testing and etc., so they're not, as long as they pass the boards, they're very happy. So they're probably not a target audience. I would agree with Mary that external assessment by their senior colleagues and peers would be more valid.
I find them not being able to make decisions as well clinically. The ones that have not taken the oral boards. I mean, there's going to be a variation, right? You just get some residents that are really decisive, that see lots of cases in real life and are decisive. But I definitely see a bigger problem with the current residents of making decisions. And I know I hate it. No one ever believes this because I never stop talking. And it seems like I would love to take cases. I hated to take cases. It was so stressful to me to be in front of a bunch of people and have to be definitive about what I was going to say and maybe be wrong. But that was the best thing for me to become a decisive radiologist. And I'm not going to say maybe they don't have the same knowledge base. I can't judge that. And I've never asked that wonderful question, which now I'm going to add to my survey about how prepared they feel. But I definitely think there's less decisiveness. And I wonder if it's because the board reviews to do it don't put them on the spot as much. Answering a multiple choice question is not quite as stressful as having to make a decision from your memory, from your knowledge, which is what you do every day as a radiologist. So I will say I've definitely seen a lot less decisiveness in our recent graduates than older graduates who did take the oral boards. And as I said, it's a spectrum because I still have some graduates who are killing it, making decisive, but I think that's, they might have always been that way. But I definitely see an issue with anxiety around making decisions more, which is a problem. I will be honest, especially in certain subspecialties, it can be prohibitive. There was one comment I'll say because I saw it. Dr. Resnick would like to reframe something from the survey. Apparently, there was something that said the oral boards had a negative impact on resident training, and he thinks it could be better phrased as a negative impact on resident preparation for practice. So that can be a good note to Anna when they write that fabulous survey up. She can take that into some consideration. Anybody else with input? Even anything? Again, ABR, if you want to respond to anything you've heard us say. Happy to hear it.
I just wanted to comment on something. It was about 20 or 30 minutes ago, actually, and I didn't want to sidetrack the conversation, but the timing of the exams is one of the least important elements for the ABR.
Please keep moving.
And this came up when I was asked at the residency RRC at the ACGME, why does the ABR give the test at the end of third year when everybody's worried about fellowship applications and interviews, et cetera, et cetera? And I said, we don't specify when you take the test. The first opportunity, you have to have 3 years of residency training, so essentially 36 months before you can sit for the exam. But if you want to take it in November, if you want to take it the following June, if you want to take it to November after that, I mean, you have 5 opportunities actually, which would still allow you to be board certified the same day. So I just want to stress, we're less concerned about the timing of this than you might think, meaning that if, for example, the program director organization were to say, we want the first opportunity to be in November of the R4 year, well, we would certainly take that under advisement and just say, okay, for us, it's a question of documenting that someone has the knowledge and skill to practice in the profession, and the timing is not nearly as critical. I would say the same is true for the certification exam itself, the final certification exam 15 months after training. I don't want to speak for the entire board to say, we'll do it whenever you want. But again, remember, the first opportunity is 15 months after. There's another opportunity every year for a total of 6 years after completing training. So it's not as if, a lot of these are constraints that are self-imposed or become a tradition within the program, or whatever other factors go into it. They're really not a major theme for the ABR. So I just wanted to mention that timing is not nearly as essential an issue for us as it might be for the people taking the test.
Well, that's fantastic. Thank you for putting that out there. That's very helpful. And I will say, I don't have the right answer for timing. I'm not crazy about the timing now. I would love to hear feedback from people that have good suggestions and can back it up with some reasons why. The one thing I do feel strongly about is that they take it at the same time. I think that if you do believe in the traditional oral board prep, it's nice if they all get the oral board prep. I've seen when people have had to take extended leaves and didn't feel they could take it on time. Later, they say it was really hard not preparing with my class, because it's like a camaraderie thing. It's a sharing board study tips thing. So I do think there is some advantage to them all taking it at the same time. And I also feel that there is some advantage to the ABR maybe giving a suggested time to take it, even if it's changed from what it is now, because I think there's this feeling of, we want to do what the majority does. We don't want it to hurt us in our fellowship if we're waiting to take it, or our first attending job. If we took it at a non-majority time sort of thing. So I would just put that as a thought to the ABR as well. But I would love to hear some suggestions about other alternative times and why you think it's right. I think that's great. I'll address a question in the Q&A while we wait for some of those comments to come in. They said, can anything to comment on hospital leadership stance regarding being aware of study time with CMS funding to pay salaries while studying? I don't know anything about that. And I don't know if anyone else on the call doesn't want to talk. That sounds more like an ACGME question to me. And clearly, if they're now sanctioning study time, my assumption is that they've thought about that. But does anyone have a good answer to that? Yeah, my assumption is they've thought about it in some way, shape, or form at ACGME, but that might be a better question for them. Unfortunately, I'm wholly uncertified and not right person to answer that in an educated way. All right. All right. That's it for now. Anyone else? We have only about 7 minutes left. I'm happy to end a few minutes early if everyone's gotten the information they needed and shared. You know, as I said, the best part of these roundtables for people like the ABR, AIRP, and other people who seek feedback is to get good feedback from you guys. So they want lots of questions. Don't feel like, or comments. This is the one time that they want the comments. So feel free to put them in there. Again, I think it can only make the process better if we get some educated comments.
And while that's hopefully happening, Carolyn, I just wanted to, on behalf of the Board of Trustees, the DR group that actually is responsible for, you know, getting this test to your trainees, we really, really appreciate the input. I can't tell you how critical it is for the decision for the BOG, the Board of Governors, to decide to move forward with potentially changing it. We really need to hear people's concerns. And the way y'all have done your survey and given us information, you know, we still have the nuts and bolts, the interpretation we will take with the quantification because we've recorded this. And so for going to that extra effort during a super busy time, I really wanted to say thank you from all of us.
Yes, thank you so much to the APDR, Anna, for that. I agree. And as I can't say enough, as I said, I've had experience with working with the ABR before in these kind of scenarios, and they do take everything, you know, to heart and really look at it critically. So your feedback is just so appreciated. And as a PD, I would like to hear more feedback from other people because maybe there are things that I haven't even thought of. So I always like to hear as well. So, but looks like we're, yep, someone else?
ABR is open for comments.
Yep, yeah. Yes, and if you have comments, you can always address Anna or I, and we're happy to make sure they get to the right place. Absolutely. Or if someone wasn't on this call and you talk to them, they're like, oh, I have all this feedback, send it to Anna and I. We're happy to get it to where it needs to go. All right. Well, I'm going to close then since we don't have many people and I get to spend extra time thanking everybody then. So I want to thank our wonderful panelists from the ABR, Dr. Wagner, Dr. Morgan, and David Laszakovits. And I would also, of course, want to thank Dr. Anna Rozenshtein for her huge effort with that wonderful survey and presenting it here as well as being a panelist. And then thank you to Ernie and Dr. Ernie Wiggins and Dr. Mary Scanlon for both being on our panel and contributing so wonderfully. So I want to thank everybody today and those who attended and gave wonderful, insightful comments as well. So thank you all very much for attending. And there will be a transcription of this faster than the last one, hopefully in the next week, depending on how quickly I can get the rest of my work done. But thank you again for attending. And thank you again to all our panelists and to Caitlin. Boys does a fantastic job of doing all the important parts of this. So thank you, everybody. Have a good day.
Thanks, everybody.
Thanks.
Thank you.
Take care.
Thank you.
Thank you. Bye-bye.